Okay, thank you. Going to the fourth speaker, defining a unique research niche at the crossroads of mycology, immunology, and oncology is Sebastian Wurster. Sebastian.
Thank you very much for the kind invitation and the opportunity to present our research at the crossroads of mycology, immunology, and oncology. As this is a session dedicated to career development, I want to briefly showcase my career path and highlight that my training was focusing on three major areas, which was molecular oncology, microbial immunology, and now most recently fungal pathogenesis, including in vivo models. I think this triangle of oncology, immunology, and microbiology or fungal pathogenesis lays a nice foundation for our ongoing and evolving research on utilizing oncological immunotherapies for fungal infections. So just to reiterate, why do we need antifungal immunotherapy? I think we have heard a lot about the limitations of conventional antifungal therapy, but I want to specifically reiterate the red puzzle piece about what we call the last third, the poor outcomes in patients with persistent immune dysfunction. Here are just three examples of studies from the MD Anderson Cancer Center. And these observations obviously gave rise to many studies on the development of antifungal immunotherapies. And it's my perception that over the last 10 years, a lot of funding and effort went into the development of cellular immunotherapies, such as adoptive T-cell transfer, or our work on the development of antifungal CAR T-cells that's still ongoing. And while many of these approaches showed very convincing, extremely powerful results in preclinical models, they are notoriously difficult to translate to the clinical environment. And we are seeing over the last 2 to 3 years that this observation seems to have reinvigorated the interest in utilizing readily available immunotherapies such as cytokines and checkpoint inhibitors. We have already seen this wonderful review that covers this topic more broadly in infectious diseases, and we're hopefully in the next couple of weeks publishing a more dedicated review of the latest updates on checkpoint inhibitors for fungal infections. So the checkpoint pathways, as many of you may be aware, are negative feedback loops in the immune environment that promote self-tolerance and prevent autoimmunity, but upon chronic antigen exposure can also trigger immune exhaustion. And there have been a multitude of studies showing that this actually plays a role in fungal infections. We have seen that both the classical checkpoint pathways, PD-1, PD-L1, CTLA-4, but also a number of alternative checkpoint targets, such as TIM3 and others, are upregulated in fungal infections. And this in turn gave rise to a number of preclinical studies like ours in invasive pulmonary aspergillosis and mucormycosis models. And while we have already seen these data in the morning, I want to highlight one specific aspect that connects it to the observation of the impact of persistent neutropenia. This was done in a pharmacologically immunosuppressed neutropenic model, and despite that fact, we saw that we got an improved recruitment of neutrophils from that limited pool to the lung, mainly through chemokine signals. And as shown in the morning, we followed up with a study in invasive pulmonary mucormycosis model that actually showed some nuances between the checkpoint pathways, and currently we believe that a low-dose block of the PD-L1 pathway has the slight edge in terms of balancing between potential immunotoxicities and enhancement of antifungal immunity. These studies and several studies on ex vivo patient samples, including from these case reports, have given us a basic mechanistic understanding about the protective features that might be enhanced by checkpoint inhibitors. And I want to highlight in broad strokes three mechanisms. One prominent mechanism seems to be the enhancement of protective adaptive immune responses, especially type 1 T helper cell immunity. Another one, as mentioned, the recruitment of innate immune cells such as neutrophils and dendritic cells. And then there have also been studies, including from our mucormycosis model, showing that those recruited cells actually have an enhanced maturation, an activation state, and even a more powerful fungicidal activity. In order to dig a little bit deeper, I want to show some of our latest unpublished data in a neutropenic mucormycosis model. And unsurprisingly, early on, day 4 after the infection, you get a strong pro-inflammatory innate immune response. But already by day 4, you see the first signals of emerging immune exhaustion. And by day 7, those pro-inflammatory signals have actually weakened despite increasing infection severity, and the exhaustion signals and inhibitory signals are strongly increasing, with the PD-1, PD-L1 pathway being at the top. But if we look at individual genes, it's actually the alternative checkpoint target, TIM3. If we give our PD-L1 inhibitor, we are seeing a sustained protective innate immune response. But despite giving the checkpoint inhibitor, we are still seeing some signals of adaptive immune exhaustion compared to both the isotype control and uninfected mice. So in summary, we have a quite profound mechanistic framework to see a beneficial effect. But it's clear that those strategies need a further improvement and potentially combinatorial strategies. And that's where our future directions and challenges come into play. And this is a predominantly clinical audience. I want to specifically highlight the focus on clinical implementation. We need to understand the synergies with antifungal, conventional antifungal therapy, and especially the sequencing and timing. All those animal models implemented checkpoint inhibitors at a very early stage during the initial inflammatory peak, whereas those salvage therapy case reports use checkpoint inhibitors after 4 to 6 weeks after several other therapies have failed. And we probably need to find the sweet spot, the middle ground. And we are currently in the process of securing both industry support and, as a larger MD Anderson consortium, trying an R01 submission to address many of these aspects around the clinical implementation, the management of toxicities if they emerge, and also all these experiments will be paralleled by biomarker studies if we can secure R01 level funding with a 3-pronged approach of RNA, single-cell RNA sequencing, and then functional immunoassays and also antigen-reactive immunoassays to specifically understand the antifungal immune memory. I want to finally highlight a second level to that program that gives it some uniqueness, and one aspect where we already have been securing successful funding. And this is the impact of an underlying hematological malignancy. We got intramural funding and an R01 grant to develop an AML model with invasive pulmonary aspergillosis and in the future potentially also other fungal infections. And this shall go beyond the exploration of our dual hit hypothesis, what happens if we give anti-leukemia checkpoint inhibitor therapy, how does that shape the natural immune response, but we want to extend that much further and beyond checkpoint inhibitors to all the new anti-leukemia therapies that are upcoming, things like macrophage checkpoint inhibitors, the CD47 inhibitors, that we will be seeing in the 5 to 10 years in the clinic, and we need to understand their impact both directly on the antifungal immunity, but also then in a setting of blast burden as an independent risk factor. And I think this approach to develop novel assays and animal models to address clinical observations, clinical questions, and deliver translational impact has been a long-proven strategy of my mentor, Dr. Contianis. And we have already successfully implemented this strategy in a couple of other projects. These are some of the unique models and assays that we have. And in particular, those in vitro assays will also become an integral part of the R01 strategy. And with this, I would like to thank all the collaborators and at MD Anderson and our extramural collaborators, and specifically our lab team, Nathaniel Albert and my mentor, Dr. Contianis, and I'm happy to take your questions and points of discussion.